copy of this, so
Okay.
you'll have it. With previous anterior inferior labral surgery, also is noted deficient anterior inferior bony glenoid with ill-defined displaced residual labral remnant. Okay?
Mm-hmm.
When we look at the CT scan, they're going to say anterior inferior glenoid bone deficiency up to 5 to 6 millimeter maximal thickness, consistent with the previous osseous Bankart. No bone is still remaining. Okay?
Mm-hmm.
So there's three options. One option is for me to go in there arthroscopically and just simply repair the labrum again. Okay? So do as much as I can arthroscopically and retension.
That's what they've done twice, though,
Yeah,
right?
that's what they've done twice. Okay? And so that's one option for me to go in there arthroscopically and repair the labrum. Advantages of that, well, you've been through it. It's a pretty simple procedure. It's all arthroscopically. There's no incisions. There's no moving or transfer of bones. You have some labrum there that I think I could probably get repaired a little better, definitely better than where it is right now. And what are the disadvantages of it? Well, you know, you failed it twice already. Now we always say, you know, I don't know who, you know, we know who did your surgery or whatever, and as a surgeon, we kind of like to think we'd have a better chance of succeeding. But, you know, in all honesty, I couldn't tell you 100% we would succeed with that because you failed twice.
Mm-hmm.
And so that would be the first option. And the second option would be to do what's called a Latarjet procedure, which is a French term for taking this bone, piece of bone here, this bone we call the coracoid, all right, and transferring it over to the front of the glenoid. And by doing that, it creates kind of a bony lesion that prevents you from coming out again. Advantages of it, well, it's very simple. I'm taking your own bone and I'm just moving it over. Disadvantage of it is not cartilage. So in other words, your humeral head's riding up against non-cartilage. And so my concern with those are long term, you can end up having a higher risk of arthritis. Third option, which is a more new option, which is we take a cadaver piece of distal tibia. And the distal tibia has a very similar morphology to the glenoid. And so there's cartilage on it, so I would reshape it. I'd use that cadaver tissue to shape it, and then I would simply just put that with some screws over right where your glenoid is. So the advantage of that is I'm recreating cartilage in the area instead of just putting bone there.
Mm-hmm.
So it's cartilage rubbing on cartilage, so there's theoretical advantages of that. Disadvantage of that, well, insurances don't always cover it, which can be an issue. Secondly, it's not been studied as long because it's a relatively newer procedure. So we don't know the 15, 20-year follow-up. There's a lot of those last procedures being done in young military populations where they have recurrent dislocations. Mm-hmm. Those are kind of the three options out there. All right.